Dr. James Powell is the Chief Executive Officer for Long Island Select Healthcare, which is a federally qualified health center with 8 offices in New York. He's the Medical Director of DDI, East End Disabilities Associates, and United Cerebral Palsy of Suffolk, Long Island. He's also the Secretary and Treasurer of the Alliance for Integrated Care of New York, an ACO that serves 9 different health centers in New York. Steve Asofsky has been the Chief Administrator and Managing Partner of a private practice in Long Island. He is the Rehab Supervisor of the Long Island Select Healthcare. He is certified through the New York State Education Department as a teacher of the speech and hearing handicapped. Welcome, both Dr. Jim Powell and Steve Asofsky.
Good morning. How is everybody? And thank you for having us here today to speak to you about common conditions of GI and Dysphagia 201, the basics and beyond. We're going to take you through a journey of the disorders of from birth right through geriatrics for disorders of such. So this slide right here pretty much tells us the story of life and how our disorders of both GI and dysphagia may occur. We may see them in infancy from babies that are born and are in the NICU, as well as it may sustain them through their entire lifespan, and or these disorders may occur at any point in time within our lifespan. So depending on the facility that you're in, depending on the population that you work with, some of you may interact with our patients who have suffered from dysphagia. And exactly what is dysphagia and what are the disorders that we see? And who is involved in assessing and diagnosing and treating the dysphagia? So myself as an SLP, I deal with dysphagia, and I'm very lucky to be able to be a part of a multidisciplinary team that has the support of not only the rehabilitation component, but also the medical world. So they assist us in identifying initially our patients and then referring. So they refer to us because as an SLP, we are the ones who are knowledgeable about normal and abnormal anatomy and physiology of the aerodigestive tract, which is responsible for the respiration, for swallowing, and also for speech. So one of the things that we always say, and when I teach my students, is the difference between normal and abnormal. Knowing normal is key because in our population, our special population here, especially with Article 16 OPWDD, our patients are atypical from the norm, and we have to also understand that disorders range. They're labels. So if you compare one disorder to another disorder, you might say, here's your first patient who's disordered, and say, wow, they're severe. Then your next patient comes in and you say, no, they're severe, then what is the other? So knowing normal is key. So then once we as SLPs assess the patient, we're then responsible for that diagnosis of dysphagia, recognizing it, and then also allocating the therapeutic component. And therapy may be from referring to the diagnostic part of it for additional medical intervention and diagnostic testing, all the way to actually hands-on therapy of the swallow. So when we think of swallowing in our population, we really need to know what is the difference between swallowing and feeding. We think that because somebody is being fed, it's part of swallowing, but it's not. Swallowing is actually the entire process of deglutition. So it's the time that the food gets into the mouth. It's the time that that individual is taking to prepare the material within the oral cavity. They pass it through their pharynx, it goes into the esophagus and down into the stomach. That's the completion of deglutition. That is actual swallowing. Feeding, on the other hand, is actually that. And this is why I say when we look at the lifespan, we feed infants, we feed children, we also feed adults. So that's placing the food within the oral cavity. And then subsequently, that person then prepares the food for them to complete the swallow. So those are the differences between swallowing and feeding, which plays an important role in what we do as SLPs and also our ancillary staff. So dysphagia, when we label dysphagia, and we say swallowing difficulties and disorders, it is any difficulty in any of the three stages that we have when we look at an oral, a pharyngeal, and esophageal, which also brings us to the title of common GI disorders as well, because we often get complaints that somebody's having difficulty, but they've already swallowed. Well, it's not within the oral cavity anymore, but there's still areas within the pharynx and the esophagus and into the stomach where difficulties may arise and dysphagia may be diagnosed. Interestingly enough, we talk about feeding and placing food within somebody's mouth. What we don't always recognize is the tongue, the palate. And I use the colors here as a painter's palette, so to speak. So when we feed somebody initially, you present it right at the tip of their tongue, especially the babies. And they taste and they open their mouths because typically we start with fruits, sweets, or the vegetables. Salt is right behind, sours on the side, bitters in the back. So the tricks of, oh, the baby won't eat the meats because they're not sweet. So you take a spoonful of the meat, you dip it into the applesauce or the pears, they taste it, they open their mouth, in it goes. We also sometimes do this as techniques for our adult population as well. But it's interesting to know where the taste is within the mouth, because often I will get evaluations, and so my colleagues do, because somebody isn't eating, but it might be because they didn't like the food. So it may be all part of taste as a disorder as well. So when we look at the different stages and we talk about oral, pharyngeal, and esophageal phase, we break them up. We're looking at different aspects of the mouth. We're looking at how does that individual are they preparing that material to push the food from the front of the mouth to the back, where the pharyngeal phase is then triggered. And we're looking at different aspects of that, which will go on a little later in this presentation. The pharyngeal stage is actually when the swallow is triggered. So the time that the bolus or the head of the bolus gets to the falcial pillars, if you look in your mouth and you have those little arches, you will see that's where the beginning of our pharyngeal phase starts, and the end is right at the cricopharyngeus, where now the esophageal phase initiates. So the esophageal phase and any deficits there is from the UES, the upper esophageal sphincter, all the way through to the LES, the lower esophageal sphincter, into the stomach. So in any of those stages, dysphagia may occur. So what are we looking at when we do an evaluation? So when a physician refers a patient to us and we have the patient in front of us, we're looking at certain aspects. So this becomes part of the diagnostic procedures. We're looking at, does that patient have an intact musculature of the lips? Do they have an open mouth posture? Is there asymmetry to the face? That's all going to then become part of red flags that come up as to how we're going to possibly even present the material within an oral cavity. We're looking at the tongue. If the tongue is rigid because our patients are so spastic, we're looking at, can they actually move the tongue to propel the material from anterior to posterior or even to lateralize, which becomes very important because then we deal with issues of gagging because they can't manipulate that material. We're looking at the buccal musculature. Do they have hypotonia? Are they low tone? Are they drooling? Do they have pocketing of material within their mouth? So we're looking to make sure that the buccal musculature is also intact. And we're looking at the palate. Does the palate hypernasality, which is indicative of potential VPI? So that's also an important part because of nasal regurgitation and protection of the nasal pharynx, and also the ability to breathe comfortably through the nose. So during an oral phase, what has to happen is, or what should happen that we look at is, we're looking to see that the individual can maintain bolus cohesiveness within the mouth without opening the mouth. So babies, either breastfeeding or bottle feeding, need nasal breathing in order to continue to consume the material. For us, if we can't breathe through our nose, we typically pop open our mouth, which also can lead to spillage of material out of the oral cavity. So we want to make sure that we have proper nasal breathing. We're looking at the pharyngeal phase. So typically, as I said before, the head of the bolus starts at the faucial pillars and ends at the upper esophageal sphincter or the cricopharyngeal juncture. And that should take about half a second to a second. So for argument's sake, a puree bolus between the oral phase and the pharyngeal phase should trigger within about 2.5 seconds entirely. So that's pretty quick. So that's, again, knowing a normal phase of swallow for just that material. We also look at epiglottis and retroflexion of the epiglottis. So does the epiglottis come down? Does it protect the airway? Do we need to worry about techniques or strategies to help protect our individual? So the pharyngeal phases are one of our most detrimental because it is the gateway also to our airway. And then we have the esophageal phase, where we have more of our GI issues. The cricopharyngeus region, we look at that aspect of it. We're looking, so as soon as the bolus enters into the cricopharyngeal area, this peristalsis move the material through the esophagus into the LES. We look at our patients who are positioned. Are they upright? Are they in a concave or convex? Are they in flexion? Do they have hypotonia? Because this all may have negative impacts on the esophageal phase. We also look at our patients through the lifespan for healthy aging, because we also know that peristalsis decreases as we age. So when we look at an assessment and evaluation of swallowing, we're looking again, as I said, to those structures. So within an oral examination, we're again looking at facial symmetry. Is there asymmetry? Does the individual have dentition? Because that will also decide what type of material can an individual have. In 26 years of treating, I've had one individual only who was able to eat raw carrots with his gums. So, you know, it all depends on skill sets, but we're looking to see if they have dentition or do they have dentures. We're looking at the oral cavity itself. We're looking at the tongue. We're looking to see if the tongue has any tremors, fasciculations, weaknesses. Is it strong? Can it move? Does the velum have any asymmetries to it? Does it look as if it's going to be deficient in any way? Are we looking to see if we can have a gag reflex, which we're going to talk about? Looking at the oral pharynx, can we get that gag reflex? Functions of the lips. Does that individual have the ability to retract their lips, to approximate the lips? Can they swipe off of a spoon? Are they going to be able to put lip closure to the cup or the drinking apparatus? So we're looking at any facial paralysis, because again, within the oral cavity, we may decide if there's a weakness, if there's a paralysis, unipolar paralysis, we might move that material to the side of strength as opposed to going in centrally, or potentially looking to place the material on the side that doesn't have any sensation because the patient won't identify with it. So again, looking at the tongue for protrusion, elevation, and excursion, lateral excursion. So for most, and again, when we go through development and we're giving material, you give a yogurt, you give a puree, the tongue will take that bolus and it will just transport AP, that material from front to back. Now put material on that, and now you have to take the material that entered. So you take a bite of a sandwich, but you can't just swallow the sandwich, you have to lateralize. So we have to make sure that the tongue has that mobility to be able to move the material or that bolus from side to side. We're looking at the velum. Does that patient have a gag reflex? Which we're going to talk about. Does somebody need to have a gag reflex in order to have a normal swallow? So that's one of our major questions that we're going to ask. Larynx, we're looking at vocal quality. We're looking to see if that patient has a cough volitionally. Will they be able to potentially identify and clear any material that might be within the pharynx? Lingual assessments, again, any limitations, we're looking to ensure that that patient has that ability to manipulate the bolus cohesively for safe transport. So back to that question, does an individual have to have a gag reflex to have a normal swallow? The answer is no. So very often I'll get evaluations based on the fact that the patient doesn't have a gag reflex, which is a cranial nerve neurological sign, but doesn't necessarily mean that that individual cannot swallow. So on that swallow assessment, we present the material. So we look at level of functioning, oral clearance. Is there any material in the anterior sulcus? Is that individual pooling that material? Is there any pooling in the lateral sulcus? What does the tongue body look like? Is there any stasis on the tongue? Reflexive biting. Our patients have these tonic bites and tonic bite reflexes. So we might decide you don't want to use a tongue blade because they're going to bite it and splinter. You don't want to use a metal spoon because they're going to crack their teeth on it. So we look at aspects of what is most appropriate. A coated spoon, a virtual indestructible spoon, so that if they do bite down, they're still safe. And we're looking at their oral defenses as well. The pharyngeal phase, promptness. How delayed is that initiation of the swallow? Again, when we were looking at the pharyngeal phase, and I had said that it's the gateway to the lungs in your airway, we're breathing during the oral phase. So if it's delayed, you can end up with something called premature spillage, where the material goes into our pharynx. How quick does that person identify that material is trickling down? Do they initiate that swallow? Is there laryngeal excursion to help protect the airway? What's the vocal quality prior as well as post deglutition or the swallow? Did they cough during, after? Is it delayed? And then also I utilized cervical auscultation, was taking the stethoscope and listening to the larynx to listen for that cessation of breathing to ensure that the vocal cords are closing, that the larynx drops back to where it's supposed to be, and that there's a patent airway and there is no change, because our patients also have respiratory distress. They have weakened respiratory systems. So they may not be able to vocalize. They may have shallow breathing. So listening with a stethoscope amplifies that for us, so we can actually hear what's going on in the event that there's silent aspirations. What do we use? Especially with our OPWDD population. So we're using materials where you can see if they can have a dry swallow. We're looking for the puree consistencies. We use ground, we use cut up consistencies of 1 inch, a 1/2 inch, 1/4 inch. We're also using whole foods. And the liquids that we may use are anywhere from the thin, the nectar, to honey, and also pudding, which is typically our purees. So we've already accomplished that with puree diets or the food material that we're using. So what we typically try to do is least restrictive to most restrictive. And then if we find that we have a query of this patient may have symptomology of dysphagia that we see at clinical bedside, we may want to then refer for more definitive diagnostic testings. So we have choices. One of the options is the modified barium swallow study, which is the Cadillac of our radiologic diagnostics. So it looks at all 3 phases at once. So you can see the oral phase, the pharyngeal phase, and the esophageal phase. So what we do is we present the material to the patient with a little contrast barium, so it highlights itself within the fluoroscopic evaluation. And we're able to see any of the deficits in any of those areas that they have: the oral stage, what they're doing with it, the timeliness, the manipulation, the facilitation of the swallow, if there's any premature spilling, And if any of those deficits occur within the pharynx, and then also the transport through the esophagus. So the modified is one that is a diagnostic and a rehabilitation tool, because if you do identify any differences or deficits within that patient's swallow, you could run it again and again using any of the strategies and techniques that we feel that are appropriate. So when that patient leaves the environment of radiology suite, we already know the most appropriate diet consistency that that patient can have if it's appropriate, as well as any of the swallowing techniques or maneuvers that we may use within therapy. Another type of study that we can use is the FEAST or FEAST. So that's the flexible endoscopic evaluation of swallowing either with or without sensory testing. Now, most of the practitioners will use a FEAST exam without the sensory testing, which then takes material, any of the ones that we had talked about prior, and typically uses a green dye for that. And what we're doing is we're taking a look at the structures. So it's no longer black and white. So these are the differences. On the left of your screen, you see the modified barium in the black and white. On the right of the screen, you'll see the FEAST results. So you can actually see what the structures look like. You can see how the patient's handling their own secretions. You can see if there's any GI issues, such as an LPR component, because of the swelling and the edema, the erythema, the redness that will be indicative of potential LPR. And you'll be able to see the differences in the material as to the amount and where exactly that individual is either pooling and or aspirating within. So the modified looks at the black and white. You usually get either a lateral view or an AP view. You get a top-down view doing a flexible endoscopic evaluation. So I just want to go through some of the deficits that we see during fluoroscopies, the MBS. So this is a patient who we see who has pooling in the vallecula, pooling into the piriform sinuses, and also now penetration into the laryngeal vestibule. So the cricopharyngeus is at this point, the vocal folds are right here. So we all want the material to go through the oropharynx and down the esophagus in this fashion. We do not want anything coming anterior. So this patient is somebody who has premature spillage. So the material went into the vallecula, it dumped then into the piriform sinuses. We have penetration, and now we have ultimate aspiration. So very often we'll hear from our feeders that will say, oh, the patient swallowed. Yeah, it's true. There's nothing in the mouth, but the deficits are what we can't see. And this is actually a patient who's silently aspirating, and cervical auscultation will be very useful here because this patient did not even cough up. So no cough reflex. This is a patient who has a cricopharyngeal or hypertrophy of the cricopharyngeus, which impedes our material from going through the esophagus. So again, this material can then kick back into the oropharynx where we could penetrate and have aspiration. But again, it's lower down after the swallow. Pathologies of cervical osteophytes can, depending on how anterior and prominent these growths go, can also impede, as you can see, the waveform of the material going through. So the more viscous the material, the harder it's going to have to go through the narrowing of the esophagus. For this patient has a Zenker's diverticulum, not often seen, but we do see it. And again, it's after a swallow. So patient has pooling in the vallecula, into the piriforms, and now into the Zenker's, which is an outpouching of the esophagus. That material acts as a sling. So it captures the material and it slingshots it back into the oropharynx, and this patient had actually aspirated, again, silently. So when we look at this, we see passage of material, especially the liquid, going past the Zenker's, but right in the proximal esophagus or the upper esophagus, we have debris that remains. So again, this is after the passage of the liquid, but yet all the material is here. So now if this patient is fed again, this pocket overfills and we shoot straight back up into the oropharynx. This is where our patient starts coughing maybe in the middle of the meal or depending on how much food or how large this is after the swallows. So we have delays. Now going lower through the GI tract, this is where we see dysmotility. So this patient, and again, was older. Dysmotility, as we know, slows down the motility. So we increase dysmotility as we age. So this patient has material in the lower esophagus, right by the LES. Also tertiary contractions. You can see these little spasmodic components within the esophagus, and also it pushes back the material up the esophagus. So depending on the rate that this patient is fed, the material never empties into the stomach. So we keep piling on more and more material. Hiatal hernia, another common GI component. So again, we don't see this in the oral stage, but this can cause GI issues, which will eventually cause dysphagia. So the material, as we saw in this slide prior, the material will eventually enter in a nice straight path right into the stomach. For the hiatal hernia, there's a block because it's going through the fundus and pushing up the esophagus. So now the material must go around. So the hiatal hernia actually promotes the reflux because it's a delay in emptying. And this patient actually did reflux. So the material went into the stomach and popped back open the LES. And we have reflux material back into the lower esophagus. So based on the modified barium swallow studies, based on the flexible endoscopies, we come up with our consistencies. And again, they're least restrictive to most restrictive. So to do this very briefly, whole consistencies is everything that one would desire to eat and in its original format. For those with physical disabilities, their foods may be cut up to help with plate setup. Cut up, we have 1 inch, 1/2 inch, and 1/4 inch pieces. So everything is cut up into that specified time frame. Ground, we have all meats, chickens, vegetables, pastas, and fruits, and everything that's down to a ground consistency, like a fine granola. All ground is moist, so it doesn't scatter, and that patient can be able to tolerate the material in a nice cohesive fashion. And then puree is the most restrictive, where everything is then presented in a fine baby food-like format. Our liquids, thin, nectar, honey, and as we talked about, pudding, which is really the puree. So thin is no restrictions. They can have anything that they want in any consistencies that they can desire. Nectar is like a tomato juice, a pear juice. We use a thicket or a simply thick to thicken the material to the desired consistency, to a nectar or to a honey consistency. Honey is that of what would come out of a honey bear or a honey jar. It looks like honey. And pudding obviously is a puree or what a chocolate or vanilla pudding would look like. So ITSE is a new component of a movement. It's the International Dysphagia Diet Standardization Initiative, which is now being recognized and also picked up by some of the institutions. It doesn't equate to the OPWDD standards, but it is something that is being used more universally because they're trying to, again, unify the types of diets that individuals are having across all institutions, as opposed to somebody on a stage 1 diet being a puree diet versus another stage 1 diet, which is actually a whole diet. So they're trying to uniform this. So more to come on the ITSE. So what's our main goal? Main goal as an SLP and also to assist with our medical personnel is to ensure or reestablish or to maintain adequate hydration, nutrition, and safety for swallowing at all costs. Okay, so that takes care of the aspect of the SLP's role and what we actually look at with regard to the management of patients with dysphagia.
Guess I have to use the mouse. All right, so thank you, Stephen. I'm going to apologize now. I'm not used to talking neck to stomach, so if my arms start flailing and I hit him, I apologize in advance. I just want to take a step back because as an internist who's been in this field for a long time, just based on what Steve said, we commonly get patients discharged from the hospital. And I never like when they do swallow valves in the hospital because one, they're sick, two, they're with staff that's not the preferred staff, and three, they're in a strange environment. So we have to take those results with a bit of caution if they're true or accurate. So just as team members, when you think about what's done on the swallow valve during the hospitalization or prior to a discharge, just be conscious of those variables and how accurate they are, that there may be some requirements to follow up with that because we commonly see that. So I'll start with saying, when we think about GI issues in our ID patients, where do we really start? And I know there's so much to talk about with this patient population, specifically with GI, but I want to go backwards a little bit, just to hopefully through this talk, just give you a couple of tricks, a couple of things that I've picked up and our team has picked up over time. A lot of this is grounded in the guidelines and the recommendations, but there are obviously nuances in the way we deliver care. So I've been in the field for quite some time. So back in 2005, we tracked data about the most common causes of conditions for our patient population. So in 2005, constipation was our 9th most common diagnosis code. It represented 2.1% of all our ICD codes for primary care. So we had all our code 95 patients evaluated. In 2020, has now jumped up to the 4th most common diagnosis code. It represents 4.1% of all our ICD codes for primary care. So is it because that we're better at recognizing? Is it because our patients are aging? Is it because we're adding more medications? I think the answer is yes, yes, and yes. And also with GERD, in 2005, our data shows our 13th most common ICD code, representing about 1.8% of our patients. And it's also climbed as well. So now it's up to the 8th most common diagnosis. It accounts for 2.2% of all codes. So, when we think about the GI issues, and some people feel at every exam or every evaluation that the bowels and skin, getting off topic here, should be thought about in every visit. So GI with our patient population. So let's just talk about the history a little bit, because I think this is where sometimes things get lost. The abdomen is one of those kind of Sherlock Holmes-like areas where sometimes it's very unclear what is actually happening, where things are presenting and what's going on. So I can't encourage the staff and the nursing staff that when they come to see the providers, that they really have a clear understanding as best they can about what the good history is. So we're talking about where is the location, what is the quality, what is the quantity or severity of it, and what is the timing of it. Timing is very key for us in certain conditions. And what's the setting in which they occur, and what are the factors that have aggravated or relieved them, and then any associated manifestations. And what I'll say is that I think the other piece that we have to be conscious of is who are the players in the field, because sometimes the way people present is different based on whether we're at a home visit, whether we're certain preferred staff, whether a day program, et cetera. So being conscious of the environment and the time of the day and or week can make a difference in the way things present and are represented. So I want to spend a little bit of time just about the exam in general. So for all our patients, you have to be comfortable whether you're the nursing staff, the DSP, or the provider looking at something. Because if you're anxious and you're unsure what you're looking at and you're not taking your time, you're going to miss something. You need good lighting and quiet environment. So, we don't, especially now in the world of Zoom, doing these sessions, we don't want you in the middle of the kitchen table with everyone else around looking at someone, see what's going on. Got to keep the patient informed as you proceed with your examination. So you're always letting them know where you're going and touching, so there's no surprises to them and to what's going to take place. We look to sequence the exam to minimize the patient's need to change position. So if you're going to look to rotate the abdomen around, you don't want them up and down and all over the place. You want to think about how you're going to sequence the exam, either yourself or giving direction to someone through the virtual care formats now. And obviously, as I alluded to, you have to respect the patient's privacy during the exam. And if you discover an abnormal response or finding, can you reproduce it? So quite often what happens is I'll palpate a part of the abdomen and I'll see a response. The question is this going to happen again? Well, it may, but what if I start talking to them about the Mets? What if I start talking to them about the weather? What if I talk how much I like their hairband or their glasses? Do I reproduce that examination? Because sometimes the distraction itself gives us an idea of their true pain or true discomfort. So I also say watch the odds. And there was a study done years and years ago. I believe it was in England. And what they determined is, what was an interesting finding, is that people who have new pain tend to open their eyes because of the surprise. People who have chronic pain tend to close their eyes as almost there is acceptance. So when I examine someone, again, either it's in the brick and mortar structure or in a deployable format, I'm more conscious of what their eyes are doing and their facial gestures in the examination than where they are in the abdomen. And when we think about the exam reproducibility of it, what I'll often do is actually have the patient and or the staff see if we can assist in elevating the head or the legs at pieces during the exam. And the reason for that is if I tighten up the rectus abdominis muscles, in theory, that if I push on that area and it hurts more, it's more likely rectus abdominis muscles. If it hurts less, in theory, that I'm protecting the deeper structures of the abdominal wall and the pain gets less. Again, something to think about because we're not clear about where pain is, specifically with the high levels of obesity and some disabilities and the syndromes. We're not always sure what the exam is going to show us. So that sometimes helps steer us with the way things are going. And again, just not just for the GI exam, but in everything we do, please address the patient, address the patient, address the patient. So when I teach med students about abdominal pain, I say that, you can actually think about abdominal pain into really 4 different categories. Because I'll say, what are the causes of abdominal pain? They'll say cholecystitis, gastroenteritis, I say, okay, that's great. Let's simplify it, because if we can simplify what the causes of pain come from and they originate based on the body's response to pain, it's easier for us to come up with ideas of what the possible conditions are, knowing their history, their syndrome-specific issues, the medications they're on, et cetera. So really, all abdominal pain can be broken down into inflammation, right? Our gastroenteritis, et cetera, because it's inflammation of the lining of the walls or the tissue. There's distension. Makes sense, stretching of the fibers. There's ischemia, which we rarely ever see, but it is out there. So I tell patients, if you don't think of it, and students, if you don't think of it, you're never going to catch it. And then referred pain, obviously. Sometimes things coming from the back, some things coming from the chest. So referred pain in our patient population is there. So as you go through your differential and you're either perhaps telling a story to the provider or the provider themselves, is if you think about breaking it down to those categories, it makes it easier for you to figure out what the diagnosis may be. And then really, where does deep pain come from? And it really comes from the nerve plexus. So you have the celiac, the superior and inferior mesenteric plexus. And so when people say, well, classically appendicitis starts around the belly button and then it goes to the right lower quadrant. Well, that's because of the way pain fibers are respond. Deeper pain starts in that plexus down around the abdomen, around the belly button, the umbilicus. And then as the appendix gets more and more inflamed, it starts to irritate the lining of the peritoneum, and that's when you get the localized response. So, when we talk about the migration of pain and where things are, that's the reason for it. So if you realize that deeper pain is very vague, and that's why the abdominal exam to me is more of detective work and try to figure out what's going on, it makes it easier for us to figure out what the possible etiologies are. So I want to spend a little bit of time with GERD. And this study is actually what changed my whole view, not just of GI issues, but really of patients in general in our IDD patient population. So back in 2000, a very old study, it demonstrated the prevalence of GERD among institutionalized intellectually disabled patients with an IQ less than 50 was about 50%. And the thing that I want to bring out about this is now, and this is done through endoscopy. So what they did was they took like a large developmental center, and I think it was, somewhere in Europe. I'm blanking on the country now, and they did a pre-procedural questionnaire of who they felt maybe had GERD. And that pre-procedural questionnaire said about 10% of the patients that they had, they expected to have GERD-like symptoms. And then they did endoscopies on all these individuals. And they found that there was a correlation between the IQ and communication and the incidence of GERD. And an endoscopy is not rule out or evaluate or diagnose all GERD. So you actually miss percents of GERD. So the numbers are probably even higher. And so why I think it's interesting to start here and pause here, I said, well, let's just think about GERD in general. When I go to have a meal, my vagus nerve starts to secrete acid so I can get ready for the meal. Now, this is a brain-driven phenomenon. Now, what happens when you have trouble communicating? What happens when you feel sick? What happens when you're stressed? You get vagal nerve stimulation, more acid secretion. So does it make sense that our patients who have difficulty communicating, are frustrated, scared, not maybe in the right situation where they feel comfortable, are going to have more acid release? Yes. Should it be considered more in terms of our differential diagnosis of other things as well? And the answer is yes. In fact, when I do medical evaluations for behavioral changes, I almost always put someone on GERD therapy if they're not on it, based on some of the symptoms and the way they present, because there's probably a 50% chance that they have it. Those numbers are pretty high. So, I say, tongue in cheek, it would be absurd for us not to always consider GERD when we discuss our patient population and what we do. So let's talk about the signs and symptoms presenting as GERD, because it's not always the classic, oh, I have indigestion, I have this pain or feeling in my chest. It's the other atypical symptoms that we see all the time. So we're talking cough, sore throat, chest pain, chronic throat clearing, hoarseness, self-injurious behavior, which is actually very, very common as a GERD exacerbating agent, a rumination, asthma exacerbations, vomiting, halitosis, loss of dental and gingival structures, increased salivation, and even ear pain. And I've seen this with all my patients over the years. So as we do the examination, we question what's going on. Again, think about this and think about how things have been exacerbated. So we talk about lifestyle modification with patient population. It's more challenging, I think, with our patient population because of the compliance and the issues. But there is some really good trials that show that you can get about 20 to 30% response of symptoms of GERD based on lifestyle modifications. But really what we're talking about is elevating the head of the bed. And what we mean elevating the head of the bed, and even my family members do this, they just prop themselves up on some pillows. Now, we're really talking about the wedge pillows, which many of you request and offer. But if not, then putting even some books on the headboard so that really allows gravity to bring things down. Now, again, I get it's not easy for our patient populations. I've had patients who slide down all the way to the bottom of the bed and they roll up and they can't accommodate that. But if we can make those accommodations for them, we can make a difference for the long-term issues that can develop. And then the foods, obviously chocolates, the alcohols, peppermint, coffee, onions, garlic. I mean, there's no real randomized trials that report on the efficacy of doing this, but there is strong feeling that avoiding some of these foods, and I could speak for myself personally, can make a difference in terms of lifestyle modifications and what we do. So really the basis of treatment for GERD is really PPIs. I'm a huge fan of PPIs. I go right to PPIs right away because I want to diagnose and I want to see if there's a response. So the studies show there's significant relief. Up to 80% of people can have relief with the PPI therapy, much better than the histamine blockers, the Pepcids, the Zantacs, et cetera, although successful. And long-term PPI therapy is extremely beneficial. So especially if you have chronic issues. Many of our patients, GERD doesn't go away. Now, there are vitamin issues. I'm not going to minimize the effect of the B12 and the vitamin Ds, the magnesium, the other things that we see. So we have to be conscious of that, and even iron by lack of acidity, and be conscious of that. But we also have to be conscious of what are the implications in terms of quality of life and long-term sequelae for Barrett's, et cetera, if we don't treat the acid suppression correctly. So sometimes people get a little bit nervous when I say, listen, we're going to go high dose BID twice a day therapy with proton pump inhibitors. And they said, okay, they'll buy in for it for a short period of time. But we want to make sure that the second dose is given before the evening meal and not at bedtime. And again, I go back to the idea of the vagus nerve, the stimulation. If we had the medicine, 30 minutes before the meal, in theory, there's more receptor blockade and there's more protection. So giving the medicine at night isn't as effective as giving it before the evening meal. So we're talking breakfast and dinner, or that variation of where they are in terms of snacks and things like that. And the other piece is, because I've been in the field for quite some time, sometimes you forget why you put them on GERD therapy, specifically if it's atypical symptoms. And we'll take patients off the medicines and we find out they were behavioral, or they started hiccuping or some other issues. And we forget that that was the reason why we put them on the medicine. So GERD has many ways to view it. And if you don't conscious about the documentation, either from the group home staff or the providers themselves, you will forget, because I don't think it's wrong at all to try to get patients off medicines. I don't think the success rates are small. And I've seen good success as we've lost weight. We've come off some medications for other issues because maybe we're treating byproducts and side effects of the medicines. But I am not always as optimistic that we're going to get someone off these medications, specifically after you hear what Steve had to say about the progression, peristalsis, disabilities themselves. So we are prone for more long-term GERD type stuff. So a little bit about constipation. So to poop or not to poop, what's the scoop? A bad line, but dad joke, I had to throw in something. Bowel movements for our patient population are vary. I have patients go 3 times a day. I have patients go once a week, and everything in between. So we want to know what is ideal for the patient in terms of their quality of life, their capabilities, the medication regimens, et cetera, et cetera. So we don't want to get sometimes so fixated that he didn't go to the bathroom, she didn't go to the bathroom today. They always go after this. But we want to maximize our opportunity to get the passage of stool going in a direction that we feel comfortable and keep them as safe as possible. So, there's primary constipation, there's secondary constipation, and then there's IDD constipation. Because the problem is we never really know, or hardly ever really know, what the cause of our patient's constipation is, right? So we talk about primary constipation or functional constipation, normal transit constipation, slow transit constipation, disorders of defecation, and secondary constipation include medication use and chronic disease process and psychosocial issues. So when we talk about our IDD patients, we don't really say, well, I think this is the cause, because there's so many variables in terms of just the medicines they're on and the choices that we make in terms of lifestyle capability and their functional and issues, as well as some of the ADLs. So and I'm going to probably get yelled at for this here, and Dr. Asofsky is one of the people that I'm sure will make a comment, but this is a Bristol stool scale. I don't love it. I don't use it. I don't advocate for it, but this is the Bristol stool scale. It's good to help give you some data information. The problem I have with the Bristol stool scale is, over the years, I've seen many patients have diarrhea, but they were constipated and they were just stooling around a significant amount of stool that retained in the colon. And so here we are thinking we're not giving them the Miralax. We're going to start holding back on medicines. But then when I do the examination, I get a little bit more of an in-depth history and see where things are. I need them to go more. So it's good for documenting trends, but just because someone has loose stool does not mean that they have diarrhea, and they could still be constipated. And to that point, we may need to give more medications to pull the stool out of their system, either manually or with enemas and suppositories, et cetera. So again, I know a lot of the agencies like to use this, and I don't think there's anything wrong with using it, but just be conscious of that. A watery stool does not indicate diarrhea, and there's not excessive amount of stool in the colon as we speak. So what are the kind of behavioral interventions we can do for the bowels as well? Do we really take advantage of the gastrocolic reflex? That after we have food go into the stomach, it sends a signal to the colon for contractions, and we take the advantage of that timing of that, sometimes 30 minutes or so after the meal. The other thing is, probably 99% of people that are on this session right now go to the bathroom wrong. That we sit on the toilets and our legs are parallel to the floor, when in theory we should have a little bit more of a lower level of where the anus is, so that if the knees are up a little bit, it allows for the passage of the stool to occur. The problem is that even as we age, we tend to get ADA-like toilets, which even are more elevated off the floor. And so that we had a lower toilet in the beginning, which allowed us to kind of just go. But now as we get older, we want to make sure we can get up and down. We're not stuck on a toilet. So it's even created more of a problem. So be conscious of the idea of, can we create a stool or stool-like pattern for allow people to go for those that are mobile and ambulatory. Now, the issue in terms of patients who are bedridden and stuff, what else can we do? How else can we look to help them perhaps after they eat, take advantage of what little gastrocolic reflex they have, would allow them to perhaps bend the legs a little bit more to assist them and try to get a passage of as the colon is contracting and squeezing, that we could perhaps get a little bit more passage for those that perhaps bed down. Now, exercise programs, unfortunately, do not improve symptoms of constipation in nursing home residents, and they've looked at this. There has been some idea that some increasing fluids and fiber intake did help in some small studies. So we all talk about doing more fluids, and that's fine. But I'm not sure the real value of the fluids. So 1.5 to 2 liters per day to increase stool frequency. I've never had, or had very few times that the staff would come in and said, we got them up to 2 liters a day. They're pooping up a storm. This is working great. It can aid, and there's definitely value of increasing the fluid in the bowels, but it may not be as robust as we want. And I say that because we have to also think about some of the medicines we give, in terms of the hypertensive meds, for example. So we love to use amlodipine and calcium channel blockers, which slow down contractility of the bowel. We quite often use diuretics, which take fluid from everywhere, not just from the legs, right? It doesn't just lower the blood pressure, it takes it from the bowel. So I think there's value in adding the fluids. I just don't know if it's as robust as people say it is, in my experience with our patient population. And then the fiber. How do we increase the fiber, either naturally through the vegetables and stuff? The problem with fiber is those who have kind of increased and gone vegan or increased their ability to take on fiber is what is their issue with cramping. Now, some of that ends up being temporary. So quite often when patients go from carnivores to vegans, or omnivores to vegans, they notice the huge amount of bloating, flatulence, and gas based on the change in fiber. That usually passes over time. It usually takes a few weeks of it. But just be conscious of what the fiber does to someone and how their response is, because some of them doesn't go away, but for some people it will go away in a few weeks. So just agents in general, just to talk about, I'm a huge fan of the Metamucil. I like it. What I did with these slides that I cut and pasted from the link from the previous slide is just talk about a little bit the adverse effect. Because unfortunately, sometimes we cause more discomfort than we help. So the bulk agents are great. That's usually my first choice. I go right to the Metamucil. It's one of the things I like to use. I use it regularly on a regular basis, but it can cause some bloating and abdominal distension. So in theory, I should probably use a little more Fibricon, but often as providers, we're kind of set in our way of the way we progress and the way we make decisions in our care. The osmotic agents, lactulose, mag citrate, Miralax. Miralax has really become my go-to in terms of response. Again, some cramping and gas with that as well. I'll use mag citrate as a single dose solution for short term, not on a regular basis, sometimes a day or two to get a response. Again, based on some of those cases I mentioned earlier, where there may be a need to get the stool out as quickly as possible. I don't use a lot of lactulose. When I was trained, we used lactulose a lot. But I agree that the nausea and the discomfort is much, much higher. I'll use it more with some patients that I question some of their hepatic issues. So quite often individuals on Depakote can get hyperammonemia due to depletion of some amino acids, and lactulose may help a little bit with that. So as a secondary byproduct of it, by itself, I don't think it's a wonderful medicine, but sometimes you have to add a couple of agents. Our studies show that patients are on 2 or more bowel medicines for constipation. So it's not like you can usually use one agent. So over the course of all our patients, from the high functioning to low functioning, they quite often are on a combination of different therapies. But again, I like the Miralax, and quite often we'll see the Miralax then added to the lactulose, and they're used in combination. How successful they are together can be up for debate, but we quite see them often used together. And then the stool softeners, the Colase We use it a lot. I think it's almost like a multivitamin for us that we just think it's going to do something. We all put patients on multivitamins. I'm not sure if they're really helping, but we do that. I think the same thing with colitis, again, has effect for small stuff. So when you talk about the low level type of constipation, the periodic type stuff and where the responses are, it definitely helps. The stimulant laxatives, the Dulcolax and Sedatabs, again, work well, but again, be mindful of the side effects. The one kind of magic, I think, in the IDD patient population is side effects are really true, because they don't really know what to expect. They don't know that they're going to have a headache, upset stomach, diarrhea, et cetera. So when they have a side effect, to me, these side effects are true. The question that always comes up is, did you ask and are you assessing for the chance of the side effects? And then Amitiza, I'm a big fan of. I've even used the lower doses, the pediatric doses for our patients in terms of a response, because it allows us to kind of get the bowels moving, and Linzess as well, also a good agent. And I find that the GI doctors like to run to that medicine quite quickly. So, other treatment options and other considerations, just in general. So just to talk about that, quite often we give enemas or we have a PRN package that says, milk of mag to suppository to enema after so many days of a bowel movement. And I think it's appropriate to have a right tiered response to what we want to do. We recommend the mineral and the warm water enemas for response. It's an invasive type of stuff. It's an invasive kind of procedure that the staff are uncomfortable with, the patients don't really like. It's not something we want to do, but when it's done, it's needed. Suppositories, again, are great, but again, in this situation, we think it's going to help them, how it's placed, how long it sits there, can they get to the bathroom, are in a position where it's going to facilitate type of stuff. Because when we have constipation, sometimes we got to think about where is the best agent. Do we come from up top? Do we come from below? Do we work the system accordingly? Because we don't want to give an excessive regimen of magnesium citrate if there's a potential for blockage. Now, some providers and team members talk about measuring the abdominal girth of an individual, that maybe we should baseline patients to look at what their abdominal size is, or at least when we start to identify problems with the bowels. Now, I can't find a lot of literature on this. Theoretically, it makes sense to think about where the changes are, but also theoretically it doesn't make sense because even after a large meal, your stomach will distend and it's going to throw off your total contents of the abdomen. So it'll be enlarged as well. But perhaps using an upper threshold to say, once it gets to this point, we need to intervene, and intervene may mean just calling a provider, reassessing bowel logs, doing some vitals, maybe what we can look at in terms of creating an opportunity for us to make sure we're not missing something else, and so that we have a level. And so that's things that some of the agencies have worked on, try to create a regimen so they avoid those unnecessary ED trips and where things are. Now, colchicine is a gout medicine, and quite a few years ago, I used to use it regularly actually for the treatment of chronic constipation. I give 0.6 milligrams once or twice a day. And I found that it worked great for resistant constipation. Went out of production for a while. There's a backlog quite a few years ago. And so we kind of switched to other regimens. But, it is available. It is a consideration and something to think about for those who are having some issues. I want to stop here for a second just to kind of talk about some of the other GI issues, non-GERD, non-constipation type of stuff, population specific stuff that we should see, because these are some of the things that we've noticed that are in our, through our eyes and our experience that isn't probably always reported. So one of the syndrome specific things that I just want to talk about is there's a Down syndrome patient population. Constipation obviously is a big issue, GERD's a big issue, but I think many of us fail to recognize the higher rates of cholecystitis and gallstones in this patient population. Now, it's been reported in some of the literature that's 2.5 times the normal patient population. So when you're talking about abdominal problems in certain syndromes and patients with Down syndrome, I would certainly consider in your workup that you look to do an ultrasound of those individuals just to make sure you're not missing something in that patient population. The other thing that we see more frequently than I thought was the amount of pancreatitis related to either one, Depakote, which causes pancreatitis, or two, triglycerides and hypertriglyceridemia. So individuals on Depakote, when you consider, I know that the neurologists and the psychiatrists often order amylase and lipase, but oftentimes it's missed. And those are the times when unfortunately you get those levels elevated. So be conscious of the cause of pancreatitis. Now, in terms of hypertriglyceridemia, what's interesting about triglycerides and pancreatitis is they don't usually cause a significant elevation of the amylase and lipase. And the reason for that is what's called saponification, where the triglycerides actually deposit onto the pancreas and kind of attack it and irritate it, but without a true release of the enzymes. So if you have someone that you're following from the medical standpoint who's on an antipsychotic or has some underlying issues or just an inherited or genetically predisposition for high triglycerides, please consider that as part of your causes for abdominal pain. And the last thing, for some reason, I've seen a lot more recently, now this is more referred pain than true pain, is kidney stones related to Topamax. Now, Topamax is commonly seen and used for everything from behaviors to seizures, et cetera. And some people use it as an adjunct to helpfully assisting in the weight loss of others. But the incidence of kidney stones appears, in my personal experience, to be a little bit higher than reported of the 2 to 3%. So when you have someone on those medications and some of these syndromes, I just want you to be conscious of some of the other things. We're going to stop there, give the opportunity to ask questions, because I know GI and swallowing could be a whole month lecture. And I know even my kids don't like to hear me speak, so I can only imagine what you're thinking on the other end here. So we'll pause here and we'll open up to the questions and take it from there. So thank you so much.
Okay, thank you, Jim and Steve. Does anybody have any questions about this session? We have about 10 or 15 minutes for questions. You can put them in the, right? You can put them in the chat. Bill just put something in if people have some questions. We're just waiting. Vincent or Maria, do you guys have any questions? We're going to wait a minute. Okay, while we're waiting for you to put some questions in. Oh, actually we have one, and then I'll do my little housekeeping. So Jim and Steve, I don't know if you can see this, but it's how often do antipsychotic treatments associate with dysphagia and constipation?
Well, a lot of times with the antipsychotics, it does interfere because it changes a lot of times their cognitive levels, their state of being. Sometimes the reactions to the antipsychotics, one of the side effects is the tardive dyskinesia, which we see in some of our patients also, which will also tend to have some effects on bolus management, the ability to swallow, and therefore we need to make changes in that aspect. So swallowing disorders definitely can be attributed with and correlated with the antipsychotic medications.
I think we don't pay attention to it enough. What we're very good at is picking up the streams, but we don't pick out the subtleties of what these medications do. I think that's one of the problems of the way the response is. So we're going to have a little technical difficulty here, Steve. Meaning that I personally feel that all of our patients should have, and the providers who prescribe antipsychotics should be querying about the bowels and be querying about swallowing. And this way it allows you to kind of think about that, because I think as we try to get an integrated approach to care, we're doing more for the therapies, but we're not always communicating. And so we have to kind of increase the thing. So I think you should, once someone goes on antipsychotic, I'd be following their swallowing. I talked about how they're doing with everything that Steve mentioned, and then the frequency of the bowels. Maybe that's the great way to use the Bristol stool chart to kind of see is there trending or changes, so you can catch as things are going on. But yes, I think it's underappreciated.
Okay. There's a few questions now in the chat. So the next one is, what is the difference between a bedside swallow and a full swallow study? Why would this be done instead?
So a bedside swallow study actually identifies the need for further diagnostics. So in essence, it should be a complete study when you're evaluating the patient. And if there's any then queries about what you're seeing at bedside. Now, bedside we use as a loose term. It could be at bedside. It can also be in a facility type outpatient where you're not in a bed, you're in a chair or the patient's wheelchair or some sort of a apparatus, but it should still be done as a complete diagnostics. If you feel that the patient requires further diagnostics, then I'm assuming that's where the term full swallow study is done or swallow study is done. That would be more like a modified barium swallow study or the flexible endoscopic evaluation of swallowing. So I guess it's when it should be done is if you're questioning your bedside findings, you're going to pursue additional testing.
Great. The next one is they said they missed the reason for the dinner time dose of the PPI.
So the concept of PPIs is to block the pump, and the vagal nerve stimulation, is usually minutes before the food comes. That's when the acid really starts to be secreted. So if we give it before the meals, it allows for the more receptor blockade as opposed to giving it at nighttime. So you get better receptor blockade with those doses.
Okay. Is there any risk to using, and I can't pronounce the name of the drug,
Colchicine?
Yes, based on some of the detrimental side effects that have been reported as a treatment for resistant constipation?
Yeah, and I threw that in just more of an awareness of that there are other options. And I have probably less than 6 patients on colchicine at this point in time, more because they've been on it for quite a period of time. I think once Linez and some of the other newer agents came aboard, the need for it went down. But yes, there's always certain risks. I guess the point I'm really saying is when you think about our patients and what the resistance are, don't be afraid to think about what else is out there in the literature as an assistance and help that, I think the one problem with our patient population is not any studies that really support the decisions and the treatments, the nuances of our care. So it was really more of a just to think about considerations. But yes, they all have risks.
Okay, great. This person says, I work with a young student who was being treated for GERD, Prevacid at HS, but seems to be suffering from relatively severe laryngospasms and gasping for air randomly throughout the day. Could this be an indicator that they need a new or different treatment?
So that falls more into the vocal fold dysfunction and more of a paradoxical movement. They could also be suffering from a spasmodic type of a dysphonic or dysphonia. So paradoxical movement can be triggered by a noxious component like GERD. I don't know if this patient has been seen by an otolaryngologist or laryngologist, but that would be the direction that I would send them in, just to see how the function of the vocal folds are actually moving in the vocal cord processes.
The other thing I would add to that is if this was my patient, I'd probably put him on BID therapy at the appropriate time of the day just to see what the response is. Does it get better? Does it get worse? So they're at HS, which means they're getting it right before they go to sleep, a Prevacid. And so I would probably switch them to twice a day before the meals for a trial period of a few weeks and to see how that reduces the variable. Because unfortunately, with our patient population, sometimes you have to make sure you cover as many variables as possible. So if we have the right dose at the right time and the right frequency, then we can see if there's a response to the medicine or not.
Okay, next question. If someone has a normal swallow study, but the person caring for them still fears risk for choking and requested a modified diet, ground foods, limited options, could this inadvertently worsen swallowability?
Great question. So did this person, in theory, is normal swallow study being a bedside, is it modified, how was identified? People who feed do fear. I mean, feeding, swallowing is a life and death component and should be taken seriously. Depending on the types of diet consistencies that this individual was placed on, my rule of thumb is, as far as the fears of the individual, that's something that they need to be counseled on, and therapy should work on that, and they should be working with the patient. But I always say that if the patient's having difficulty and the feeder sees that, they can always go down in the consistency. So if somebody's on a whole, they can decrease it. So for argument's sake, I'm on a whole diet, but I have pudding, so I actually eat puree. But I can go out and I can have a steak. Somebody, depending on what that person's diet is, will it inadvertently worsen the swallowability? No, I don't believe so. But again, everybody's an individual, so it's a case-to-case basis. But if that person is fearful of feeding, you can actually hurt that person worse if you're giving them or hesitant to give them the material that is appropriate. So I would really recommend more intervention for that kid.
And the other thing I would add too is the shoveling and the pacing, so that sometimes smaller pieces doesn't mean it's safer. Sometimes it's actually worse, right? Because there's more gets shoveled into the mouth. You have to worry about pacing. How do we kind of break up the timing so they allow it to swallow? It's one thing to have a piece of meat or something this size. But when you have a whole bunch of it that's smaller size, you can cause a major problem. So shoveling is definitely an issue for us.
Okay. One more question. Should it be best practice if there is aspiration pneumonia to have a swallow study and or placed on treatment for GERD?
Yeah, so the swallow studies should definitely be identifying aspiration pneumonias. We should be looking at the diagnostic aspects of that and to see if that individual can accept and tolerate and utilize cognitively also any strategies or techniques to assist with the potentials for pneumonias. If the patient has severe aspiration pneumonias, depending on whatever consistency that they're on, we're also going to take a look at alternative means of PO intake. So that may be with a G tube if it's temporary, or more permanent, a G tube or a G tube. So we're going to look at things of that nature as well. As far as the GERD aspect of it, sometimes the aspiration pneumonia is not always a top down. So when somebody has delayed coughing, somebody after the meal, it might be definitely a GERD or a retrograde movement of the material back up into the oral pharynx, and that's what's causing the aspiration pneumonias. So further diagnostics, regardless of the GI tract, is warranted in those cases.
And I don't think GERD therapy fixes aspiration pneumonia, because if you have material, whether it's acidic or non-acidic, going into the lungs, it's just changing the pH of the material. So through those slides as Steve showed, whether it's Zenkers or the other issues that are going on, the GERD therapy may be a piece of the whole puzzle, but definitely not the be all and end all.
Okay. I have an individual who is currently on puree and nectar thick liquids, but he still coughs when eating and drinking. Speech eval was completed and suggested that individual has a modified barium swallow study. Individual, however, has an extensive psych history and will need sedation. Will the test be effective if done under sedation?
The answer to that is no, because you need the patient to be a participant of the eating process. And typically we don't want to have anybody feeding and who is not cognitively there and a participant. So no, the individual would not be a candidate for a modified barium swallow study if they're being sedated. Nectar thick liquid, they might want to also try thickening into a honey consistency liquid and see if that's helping, or also to change the apparatus as to how that individual is receiving. As Dr. Powell was stating, the bolus size matters. So it depends on the apparatus that they're taking. Are they taking too much? Are they taking too little? Is it through a spoon? Is it through a cup? What's the head position? So you can look at things on the outside before you actually go into a modified barium swallow study, because that person would not be a candidate.
Okay. Can you comment on the use of Reglan and evaluation of long-term use and or taper?
So I used to love using Reglan. I used it often. I found the patient population that was most successful for me was actually the CP patients, because of their body habits, and the wheelchairs, and the inability type of stuff. The problem with Reglan is one dose, the first dose, can cause long-term irreversible side effects. It's not a safe medicine. But when you have to weigh out the issues of it, so I've used it up as high as 10 milligrams. And I try to get them to taper down over time. So, usually when I do trials of GERD related and motility related stuff, I usually use the idea of 6 weeks. I want to treat someone for about 6 weeks to see how they do. And then we look to taper down. I still have probably 2 patients that are still on, and I'm talking years, but because they've had so many other issues, we've had discussions with the family and the staff to say, listen, this is not the safest medicine. Like many medicines aren't that safe. But it is being effective for them. But as we've tapered the dose down, the symptoms came back and it became severe, and it was really debilitating. So very few, but I have found it for those right patients successful.
Okay. Swallow studies are usually done in a clinic one-to-one setting. Routine eating in the home setting has many more distractions. So can things be missed in the or structured assessment setting? In the more structured assessment setting, sorry.
So the more structured assessment setting is in the clinic one-to-one.
I think that's what they're
Yeah.
saying.
Again, you would have to speak on the level of the individual doing the assessments as well, with more distractions. Are they talking about that the clinician is being distracted, the patient is being distracted?
I would think that the patient is being distracted and not as accurate because the variables of the staff, the involvement, the food, the processing piece.
So, yes, I would then venture to say that the setting on a more one-on-one basis, you have more of attention of the patient. But at the same time, you also have to look at their naturalistic environment because decisions have to be made based on what they're doing within their group setting as well.
But what would be interesting is if the testing that Steve does is quote unquote normal and there's patient distraction in the house, I think that's the variable that you address. So is there timing of their food, different time of the day? Do you think about where things are? Do you think about different types of foods to help minimize the distraction of what's going on? So that actually may be helpful to get a test in that closed environment and have normal findings and then have abnormal findings in the patient's residence.
Okay. Do you see a lot of patients that end up with Barrett's esophagus and or esophageal cancer due to long-term GERD?
So what's interesting is a lot of my older patients have Barrett's esophagus because we never appreciated the GERD findings. Originally, and I have to look at this data, I apologize, I don't have it off the top of my head, but the theory used to be 10 years of symptoms requires an endoscopy. And it wasn't based on severity of symptoms originally. And again, I'm quoting some older data. It was based on duration of time because we talk about pain, we can't appreciate what the pain is. So if you've had, atypical symptoms for 10 years, then maybe you should be evaluated for endoscopy. So that was kind of the original feeling of that, because we'll try to catch the Barrett's, keep them in a high dose proton pump inhibitors, and hopefully decrease the opportunity for them to progress into some sort of malignancy, at least and or follow it to minimize the severity of the disease. So I haven't seen as many, and the honest answer is we're actually doing less endoscopies on our patients, because with the advent of a lot of the Cologuards and stool testing for our patients, we're getting a little bit less of the colonoscopies unless they're abnormal, where the GI doctors would say, well, as long as we're here for the colonoscopy, let's do the endoscopy. So I find I'm seeing a little bit less of the endoscopies being done, which may not be a bad thing.
Okay, we have one final question. I have recently seen articles about using neuromuscular electrical stimulation devices to improve the ability to swallow. Do you have any experience with this? Does it have value?
Yes, I actually use NMES in a lot of my patients because it's one way that we can implement strength and re-education of muscles, the larynx, pharynx, and also within the buccal musculature. And we've had some great success with our patients with this.
You got a great Thanksgiving story, right?
Yes. So we actually have a patient who had multiple surgeries. He had a reconstruction of his spinal cord, the spinal column, and it displaced the anterior wall of where the pharynx is, and he no longer has retrograde movement or retroflexion of movement of the epiglottis. So he was NPO. So we're using neuromuscular electrical stimulation lower down on the pharynx, and we're increasing the pharyngeal constrictions so that when the material drops down, because he doesn't have the retroflexion to come down, we've been using the NMES from March till now. So he was told that he would never eat again. And my goal for him was to have a Thanksgiving dinner for him. And he is going to be able to do that in a ground consistency. And parents are elated. Because like I said, again, this is somebody with special needs. He's had adversities his whole life. This is yet another. And we're able to give them that aspect of it. So yes, I use that, and I actually use it on the babies as well. So, it's very hard to have a baby stick out their tongue, hold it, bite down and use a Masako, but because they can't. So we use that musculature, the NMES, and we use the musculature to strengthen through that avenue. And we've had a lot of success with it.
Okay, we have about a minute left, so I have one last question here. Do you have any patients who underwent Nissen's fundoplication, and do you have any pearls in their management?
So we've had quite a few patients have the procedure, and that's wrapping the top part of the stomach to help keep the acid down so they don't have severe reflux. The problem is, and now it's being done laparoscopically where it used to be done open. The problem is they don't last forever. So over time, they will undo. So most of my patients, so I've been in the field since 2003 to now, it's a while, I guess, will end up on PPIs in time. So for the short period of time, 5, 10 or so years, I think it works great, but it's not a forever treatment in my experience with our patient population.
Okay. So I'm going to stop the recording.